topic so nice. We are happy that we are the one part of the team HSCPD. And today also our second program in this HSCPD event from the Indian Society of Radiographers and Technologists. We have the three members participating in this, including one radiotherapy topics also. So, congratulate to all our members, those who are presenting papers and those who are attending this program also. Wish you all the best, all success for these Asia CPD programs. Thank you. Thank you, Shashi.
Thank you. Thank you so much, sir. Before starting the session, all the participants, please note that I request everyone to mute your microphone and kindly avoid background noise during the sessions. And as well, please note, post relevant questions or comments in the chat box. All the questions related to all the three speakers, the questions will be taken at the end of the third presenter. Dear participant, please note that all the questions, whatever you post in the chat box, will be answered, will be replied to your questions at the end of after the third speakers. So regularly you put the questions in the chat box. I will pick those questions and I will ask with the speakers at the end of the sessions. And in between, if it is any poll, any questions, anything, you promptly put it in the chat box. And please adhere to the specific instruction provided from the webinar host or moderator. So let's move the session. The first session, we are going to have the topic of intraoperative marvels in MRI. The first presenter is Professor Paneer Selvam, who's working as a adjunct faculty of medical physics in the Department of Radiology and Imaging Science, Sri Ramchandra Institute of Higher Education and Research, Chennai. The major achievements, he is one of the renowned faculty in the teaching for the MD, DNB, FRCR Part 1, BSc and MSc Medical Imaging Technology and MSc Medical Physics. Is also quality assurance and safety program for JCIA and NABH accreditation process. He is having a vast experience, 38 years teaching experience in the field of medical imaging. He's also published 5 publications in national and international. You also please note that he's having more than 650 guest lecture sessions across the global, not only from the India and also from the abroad. And also he's got an award of Professor Kakala Subbarao Lifetime Achievement Award and Dr. VP Narayanan Lifetime Achievement Award and Professor C. Rathinam Smriti Endowment Oration. So with this note, I welcome Professor S. Paneer Selvam, sir, for the talk. Over to you.
Very good evening to all of you. Very happy to join this 46th Asia CPD program hosted by ISRT. First, I would like to thank Mr. Suresh Malayath, who is the General Secretary of ISRT, for giving this wonderful opportunity. Today, my session is going to be on intraoperative marvels in MRI and overview. You know that a lot of development, technological development happens in our field. And one of the very important latest technology is intraoperative marvels in MRI. The benefits of applying MR imaging during surgery has been recognized for many years. However, more recently, the field has seen major growth in awareness and usage of MR guided imaging, particularly for neurosurgery. Intraoperative magnetic resonance imaging MRI technology which I am going to explain you, to create accurate pictures of the brain that guide them in removing the brain tumor and the other abnormalities during the surgery, basically. Okay. IMRI refers to an operating room configuration that enables surgeons to image the patient via an MRI scanner while the patient is undergoing surgery, particularly during brain surgery. This IMRI reduces the risk of damaging the critical parts of the brain and helps confirm that the surgery was successful, or if additional resection is needed before the patient head is closed and the surgery is completed. A single slide about how an MRI works. All of you know that MRI uses a strong magnetic field and radio waves to create detailed images of the organs and tissues in your body. MRI is especially helpful for imaging the brain. IMRI is available in a range of strengths. We know that commonly for imaging we do 1.5 Tesla and 3 Tesla. And of course, we also have permanent magnet of 0.2 or 0.3 Tesla. Here, low field units less than 1 Tesla have the advantage of smaller in size, simpler operating theater preparation, and portability, but they are disadvantaged by relatively 1.5 Tesla and 3 Tesla option that provide better spatial and contrast resolution, enables the surgeon to more accurately evaluate the findings on an image. Coming to the IMRI configuration, what are the different configuration we have in IMRI? There are two configurations are there. The first configuration requires that the patient to be moved to the magnet room to obtain an image. For example, this is the operation theater suite. Patient is going to lie on this table. The adjacent room, we have an MRI machine. So if the neurosurgeon wants an idea about the procedure, he can shift the patient to the MRI room, which is adjacent to the operation theater, and the MR image can be done before closing the brain or completing the surgery. So this is the first configuration. Remember, in first configuration, patient will be shifted to the adjacent MR suite. What about the second configuration? The second configuration is the MR equipment itself can come inside the operation theater room, where the MRI equipment is going to be moved on the rails, what we call as a ceiling mounted system. So the MRI room, equipment from this room can be shifted to the operation theater itself, so that no need to shift the patient. This is the second configuration. So I told you there are two configurations. In the first configuration, patient has to be moved to the magnet room. In the second configuration, MRI magnet itself will be moved to the patient in operation room. Comparing the two configuration, the later one, that is this configuration, has the advantage of not moving the patient from the operation theater during the surgery, which enhance the workflow and safety in terms of airway control, monitoring, and aid fixation. That is the advantage of the second configuration, but it is going to be expensive when compared to the first configuration. Compared to all the other imaging types, high-field IMRI requires the additional cost of specialized operation suite, instrumentation, and longer anesthesia and operating room. So that is going to be a what you call very expensive process as such. If this is going to be an operation theater, if MRI is going to located here, So we have to see the compatibility. All the equipment or devices which is used in the theater should be compatible for MRI. So the cost aspect is going to be very high. But what is the outcome of this? I have referred few literatures. Many peer-reviewed articles reported the benefits of this imaging. One of that is which concluded that 41% of cases, the use of IMRI resulted in extended tumor resection. Remember, 41% of the cases resulted in extended tumor resection. The another study concluded that 27.5% of case, the original surgical plan was altered based on the intraoperative MRI finding. You see the importance of this IMRI. Though the doctors use imaging tests to plan the brain surgery, real-time images created with the IMRI are crucial to locate the abnormalities if the brain has shifted. You know that the brain often shifts during surgery, which makes the pre-surgical imaging no longer exactly precise. So pre-surgical planning would have been done, but the brain shift during the surgery, so it may not be exactly precise. But imaging with the IMRI during the operation gives the surgeon the most accurate information. That is a major advantage of IMRI. And also, it distinguishes the abnormal brain tissue from normal brain tissue. It can be difficult to distinguish the edges of a brain tumor and separate the normal tissue surrounding that from the abnormal tissue. But imaging with the IMRI during surgery helps confirm successful removal of the entire brain tumor. Intraoperative MRI allows the surgeons to achieve a more complete removal of some brain tumors. For this reason, IMRI has become the standard of care for operation to remove certain brain tumors. However, as I mentioned, the published studies shows the use of IMRI increases physicians' ability to detect residual tumor, leading toward an improved rate of procedural success. Of course, CT also in some angle it is used, MRI also. So using the CT and MRI as our eyes and using indirect approaches rather than the direct line of sight. That is the greatest advantage of IMRI. There is another option, intervention 2. We also can have a catheterization lab, intervention radiology division near the operation theater. And this also can be used like how we use MRI as a tool. The uses of MRI, that is IMRI, it is used to assist in surgery to treat the following condition. Of course, one is the common one is the brain tumor, and the patient will have a symptom of epilepsy or essential tremors, glioma, neuropsychiatric disorders, Parkinson disease, pediatric brain tumors, of course, in some case of pituitary tumors also. Taking the advantage of IMRI, so for example, this is a preoperative itself. So this is an overall idea about IMRI, but as a technology people like us, we should have a good idea about the technology behind this, how it is done. So we need a stereotactic frame for this, which is used in a surgical technique. For what purpose? For precisely directing the tip of a delicate instrument in 3 planes using the coordinates provided by the medical imaging in order to reach a specific locus in the body, that is a particular point in a body. What you see is the stereotactic frame. Okay, so this frame will be used in localizing the tissue which we are planning for surgery. And of course, what you see, this image is a component called as copper sulfate solution, which is going to act as a solution for marker actually. What do you mean by that? See, in this frame, to localize the tissues, there is a lesion, we need a fiducial marker. Fiducial marker means it is a marker which is used to localize the point, used as a standard of reference for measurement or calculation a fiducial point. That's how the fiducial marker looks. Basically, this markers is available in different sizes according to the location we can use. It is made up of an acrylic material, and this fiducial marker in this acrylic, like a capsule, it is filled with a solution which I previously mentioned, copper sulfate solution. This copper sulfate solution, when you do the imaging, when you fix the fiducial marker in the what you call this one, you will be able to identify it in the MR image. It will be highlighted and seen the fiducial marker. That is the advantage. Electa is the company currently has a product called Lexial Stereotactic System. The frame which I shown you is from an Electa company, which consists of a frame and arc made in aluminum that is used in stereotactic surgery. This particular frame works, that is, the stereotactic surgery works on the basis of three main components. First one is a stereotactic planning system, including atlas, multimodality image matching tools, coordinates calculator, we call it, because we have to measure the details. A stereotactic device or apparatus, and a stereotactic localization and placement procedure. We have a coil. Here the surgery also means there is something called as X knife and gamma knife. People working in radiation oncology, we know that a minute small tumors can be destroyed with the help of a X knife. X means it's basically by using a linear accelerator. We have a used for the brain surgery. So this is the brain coil you are able to see here. Inside this, you are going to fix that stereotactic frame which I showed earlier. So this is the frame which we are going to fix it inside, and it is compatible, and the coils are designed in such a way that frame will go inside, and the alignment of this coil and the frame will be done by the technical people and the clinical people. Make sure that it is exactly horizontal. With the help of spirit level, they make the minute adjustment, and they have a small screws in the frame to adjust the level of the frame also, so that whatever they plan, it should be exactly localized. They also have a flex coil, which is used for MRI, because in some case they also handle the open surgery patient also, open brain. In that case, we may not be able to use the head coil, whatever I have shown here. For that purpose, we have a flex coil also in MRI. Coming to the safety aspect. Now we have learned about what actually the different configuration we have for IMRI. And in IMRI, the stereotactic frame, which is used for localization, how it looks, and we use the copper sulfate as a fiducial marker, because that fiducial marker play a vital role in localizing the lesion handling. Now, finally, we also should see a couple of safety aspects in doing this IMRI. Good coordination among staff is needed, particularly the staff nurse, OT technician, radiology technologist, and the neurosurgeon. Because before doing this procedure or shifting before to MRI, it's a teamwork. All of them should have a good coordination, making sure that any non-magnetic materials are there. All the material what they use should be a MR compatible material. That they have to ensure. So the material is in OT chute, they should ensure it is MR compatible. That is the reason we say good coordination among staff. And this has to be checked twice before shifting to MRI. Yeah, like infusion pumps, multi-parameter monitors, everything. Okay. And crucial parameter which the people should understand. So with this, I would like to conclude. So I have given a explanation about, as a summary, I'll give in a nutshell. First, I explained to you what is IMRI. Then I told the two different configuration. In first configuration, patient will be shifted to the MR room, which is located adjacent to the operation theater. And second configuration, the MR equipment can be shifted to the operation room, but it is expensive, which is going to move by the ceiling mounted system. Then I explained you for the surgery, we use stereotactic frame to localize the tissue. I also told you the coils, what we use for that purpose. And finally, I explained you about the safety aspect has to be taken care during what you call a high MRI procedure. To conclude, this IMRI will bring to our patient population the latest technology and in turn the latest surgical capability. So with this, I conclude. Once again, I would like to thank the organizing committee for giving this excellent opportunity for me to share the latest technology in our field, IMRI. Any
Thank you. Thank you very much, sir, for the wonderful session. So we'll move ahead with the next session. We are going to have from Anudeep Kaur. The topic is the innovations in compression techniques for mammography. A request, dear participant, kindly mute your mic so that we can have a wonderful sessions ahead. So we have a second speaker, Mr. Anudeep Kaur. She completed her BSc in Medical Imaging Technology from Nite University from Mangalore, Karnataka. And later, she pursued master degree, MSc in Medical Imaging Technology from University College of Medical Science, Delhi University from Delhi. So earlier, she worked as a senior CT and MR technologist at Yashoda Super Specialty Hospital, and later moved to senior radiology technologist at Apollo Clinic, Guwahati. And presently, she is working as an assistant professor at the Assam Royal Global University, Guwahati. So with this note, I welcome Ms. Anudeep Kaur for her talk in the topic of the innovations in compression techniques for mammography. Over to you.
I welcome you all to the 46th CPD happening in India online this time. And my topic for today's presentation will be the innovations in the compression techniques for mammography. As you know, mammography requires a certain compression. And first of all, we need to understand why do we require this compression, right? So the compression is basically required so that the thickness of the breast tissue is reduced. Secondly, the overlapping that happens because there is too much of granular tissue and the fat present in the breast tissue. So what we want to reduce the superimposition of that breast tissue. Thirdly, another aim is to reduce the scatter that is produced during the radiation exposure. Now, the third reason, which is the reduction in the X-ray scatter, is a minimal concern for us, and the rather two, thickness of the breast and the superimposition of the breast tissue are the major focus why we give the compression in the breast mammography. So the uses of this compression techniques will be our standard mammographic procedures and the digital tomosynthesis, the contrast enhanced mammography, the stereotactic breast biopsies, and the positron emission tomosynthesis, right? So the compression is varied along all these techniques. Primarily, we have a high compression when we are using the mammographic techniques like the standard mammography, digital breast tomosynthesis, and contrast enhanced mammography. In these, we usually apply a compression force of around 10 to 20 kgs, and we compress the breast tissue to around 3 to 6 centimeters. It is usually used to avoid the motion blurriness and to optimize the image contrast. Then comes our stereotactic breast biopsies. Over there are our major focuses so that while we are doing a biopsy, the needle can be properly placed. And for those reasons, we have to give some compression, but it is not as much as the one we give in a standard mammographic procedure. So here the compression will be mild to moderate. And then lastly, when it comes to the positron emission techniques, over there we give a very minimal compression because here we want to make sure there's a proper blood flow in the breast blood vessels so that the radio tracer can be properly imaged. Therefore, the compression force are pretty low, and it will be somewhere around, as given over here, 2 to 5 kgs. Now, the standard compression technique that we use most commonly is the where technologist places pressure on the pedal, and the as you can see over here, there's a compression pedal down there, and mammographic technologist will place the pressure with the foot, and the pedal will go down and compress the breast tissue. So that is our basic, the general radiographic mammographic procedure. Now to understand why do we require different type of techniques to compress the image, there were studies conducted to find out if the normal compression has got any kind of problems to it, right? And so we can see pain is one of the major problems that came out in a lot of studies. And a lot of journals you can see where people have complained of high pain because of the compression. Secondly, there have been cases of hematoma where because of the high compression, patient has complained of developing hematoma and further necrosis of the breast tissue. Similarly, there have been cases of elderly patients who have got underlying patient has complained of developing hematoma and further necrosis of the breast tissue. Similarly, there have been cases of elderly patients who have got underlying bone disorders like osteoporosis, osteopenia, where the patient have further complained after going through a mammographic procedure that they have ruptured a rib, right? And then there were studies conducted to find out that a lot of time, because of the compression, a fat necrosis could be a fat is misdiagnosed, right, as malignancies. Then comes, it can also lead to sometimes temporary nerve compression, which is a very rare finding in the compression studies, but it is one of the major findings again. So, what are the challenges and problems that we have seen so far? First is our pain and discomfort, which is very high because of the compression from mild to severe. Everybody have a different pain question, right? And because of that, people usually everybody experiences pain, but some people might experience high category of pain. Secondly, it can cause bruising of the skin and the skin irritation if the compression patient not visiting, right? Third, the reduced blood flow. Because of the high compression, at times what we have is a reduced blood flow, and especially in the techniques like PET, we need to make sure the blood flow is not compromised so that we can image the radio tracers. Another problem that we have seen is the rib fracture. So there is a risk of rib fracture in the patient that are osteoporotic, right, in elderly patient. And lastly, because the compression for different people will depend on how much a technologist will deem it to be correct. So everyone have a different way of looking at it and applying the compression, right? So there are chances that there might be a variability in the compression techniques from one hospital to another and between two technicians of the same hospital as well. These are the basic problem and challenges. So the factors influencing the pain perception could vary from different patients, right? So the first is the compression pressure. Because of the amount of pressure applied, that is what the pain perception of a person might vary, right? The amount of pressure applied during the compression can affect both the sensitivity and the specificity of the mammography. Again, because of the different categories of the breast density, the pain perception again will be different. There are 4 categories how we divide the breast density in. So first is the breast which is entirely fatty. Second is the one where the breasts have got scattered fibrogranular density. Third, where we have got a heterogeneous density of the breast. And lastly, we have got a entirely granular and the fibrous density of the breast. So given the different type of the densities that comprises a breast, the pain perception of a female will be different. Again, given the psychological factors, now a patient's pain perception could be also depending on the psychological factors. It could be the anxiety and anticipation that they have because of the pain. It could be because of the results that they are predicting or the pain that they are expecting. Sometimes it is the side effect, so they fear coming for a radiography, or the familiarity of the procedure if they already know how the procedure happens and now they are scared, right? So those are the things that influence how they feel the pain. Lastly, we can see now there are different types of compression techniques. The first was the standard that we have seen, right? Now the compression another type of compression technique that we regularly come across is our spot compression or the cone compression techniques, where we have got a smaller paddle which will only give us focused compression to the area where we have a doubt that there is some kind of a granular density or a tumor or any kind of a pathology that we are suspecting, right? So it gives a targeted compression in the suspicious area. So this is something that we can use. That way also we reduce a slight bit of compression. Okay, now we'll go for the major upcoming new technologies or the new innovations in mammographic compression techniques. So the first one that we have come across, we get to see nowadays is the automatic compression control. It is finding an increasing adoption. A lot of people and a lot of scan centers are moving towards acquiring an automatic compression techniques. So here what happens is the compression force is applied consistently over the entire area. Okay, and the machine automatically adjusts the pressure based on the size of the breast density and the elasticity of the tissue. So they have got certain pressure sensitivity with what they can try and manage that the entire area gets a equal amount of pressure, right? So this is a automatic compression control which is gaining a high popularity in the new compression technique. Secondly, we have got something called as Sigma paddles. In a lot of European countries, currently, we have got a Sigma paddle where the pressure is recorded, the amount of pressure. Like earlier, when we were doing the standard mammographic procedure, the paddle we used to apply force. to give the compression. But here what we are doing, we are giving pressure and not the force, right? So when we apply a certain amount of pressure, the pressure is getting recorded and we know how much pressure we are applying, and depending on the different sizes of the breast, we can apply higher or lower pressure, right? There are, you can see the LED lighting over here, and they will determine how much pressure we have applied, and accordingly we can compensate for the smaller breast and the larger breast, and it will adjust or divide the pressure properly among the entire breast tissue. So this is another new modality or the new innovation coming in the field. So another technology that we come across, a new technology, is a smart curve system, which is designed by Hologic, and it is also gaining a huge popularity among the new upcoming innovation. Here what we do is, earlier we used to have a flat pedal which would compress the breast tissue. So given this shape of the breast tissue, we could not adjust the compression evenly across the breast tissue, right? Now with the curve, which is designed to facilitate the shape of the breast tissue, here we are able to give a even compression across the entire breast volume, right? So this is also gaining a lot of new popularity, and people are opting for something like a smart curve. Another innovation that we are seeing in the system is patient assisted compression. Here it is still the study is still in a prototype, and there is only one center that have employed it, but it has proven to give a very good result, and a lot of patients are facilitated by the process. In this process, what happens? Patients are allowed to control the amount of pressure or the compressor being given to the breast under the supervision of a technologist. So initial compression is given by the technologist, and further compression is determined by the patient's pain sensitivity, and they have a control of how much compression they want to take or where they want to stop. This really helps them comfort and give a good result. Next is something called as soft pedal, that is specially optimized fully tilt pedal. In this case, what happens? The pedal of the mammographic compression device, it basically tilts according to the shape of the breast tissue. So as we can see, the thickness towards the patient's body is higher, and towards outside it's very much lower, right? So when we want to give the compression, if we give the same compression over the entire area, we are not able to get a fine image or the optimized image contrast, right? But in the case of the soft pedal, what we are doing is we are giving the even compression depending on the thickness of the breast tissue from interior side to the exterior portion. Okay, so this is one thing that is again gaining a lot of popularity. Now another one is MammoCat Advanced Full Field Digital Mammographic System. In this CAT system, what we have, it is designed to lessen the need for painful breast compression by making sure that it has got a curve which will define the shape of the breast tissue again. So basically the flat surface where we used to keep the breast, that surface is curved, and that surface itself is according to the shape of the breast tissue to hold it in place, right? That way you are able to avoid the motion blurredness, and the compression applied will be evenly distributed again. So this is again which is still in an investigation phase, and there is still study going on it. So there is one university, John Hopkins, which is currently having this system, and they are trying to find out more data on how it can affect the patient comfort and reduce the pain receptivity in the mammographic procedure. Another procedure which is upcoming is the two-step compression. This is also gaining a lot of popularity. In this compression technique, what happens exactly is, initially we apply a full compression to the breast or the firm compression, and later on for the second stage, the compression is slowly given so that only the patient can decide when and where to stop, and we can evaluate how much compression needs to be given. So this is called a two-step compression. This is again getting a lot of popularity among the people, and this technique is employed in one of the Siemens system called the Mammomat revelation. Here you can also see the paddle is a bit softer, so it bends and tilts according to the patient compression requirement. Okay, so if the breast is not able to entirely take up the force, the paddle will slightly tilt and make space for the even compression. Lastly, again, we have got a foam cushion compression, which is already in use. Here, there is the technique basically is that to help soften the blow when we are giving the compression, the flat surface at the bottom is really hard. So to take up the pressure, the surface is basically made of foam so that it reduces the discomfort of the traditional mammographic unit what we used to have, where the lower paddle is very hard and it's kind of very discomforting for the patient when the positions are changed, right? So these are the things that we are already using currently, and there are some of these systems already employed in certain centers. Now, the upcoming or the future promising technologies that we are seeing, which are still in prototype or experimental phase, are the air-inflated cushion compression and the thermoplastic cushion compression system. So in the air cushion compression paddle, it's still in the prototype stage. We do not have a picture or access to a picture of it. But what happens here is it's an emerging technology where basically the paddles are incorporated with inflatable air cushions that conforms to the breast shapes. Okay, so it will basically take up the shape around the breast accordingly and according to the mass of the breast tissue, and we can get a even compression around the breast. And also the compression is, since it is given by the inflated paddle, the compression will not be a hard compression, but it'll be softer to the skin, right? So this is a upcoming technology which is still in the prototype. Another upcoming technology that is still in the prototype is the thermoplastic compression sheet. In this sheet, what is happening is we take a malleable thermoplastic sheet that can be molded around the breast according to the breast shape, and when warmed, it will take a proper shape and hardened up, right? And then we can use the same technique and try to compress the breast for the scanning. So this is again still in the experimental phase, and the prototype is only designed. It is not available in the market, but it seems to be a promising upcoming future of the mammographic compression technique. So in conclusion, what all we have seen is that the future, what we need is basically to balance the image quality and patient comfort. We require imaging compressing devices which can actually reduce the discomfort and give us the optimum image quality at the same time, right? So what we are trying to look forward is that there are new techniques where the discomfort is reduced and the image quality is optimal. Secondly, the key innovations that are shaping the future that we looking forward to, one is the first would be the smart curve. The curve paddle really help people with the even distribution of the compression over time. Second is the pressure based compression, because it is not the force based. The pressure based compression really helps people with the reduction in the pain and discomfort. So these are the two innovative future ideas that people are looking forward in the industry to get more adaptability. And the another one that we are looking forward will be adapted in the market will be the air cushion paddle and the thermoplastic sheets paddle, right? So these are the ones that are promising innovations that that we can look forward to in the compression techniques. Now looking ahead, we want a patient-centered approach. So with the innovations, we hope there are new technologies where AI can be used to drive the compression, and there are more clinical, and we are looking forward to more studies where we can actually come up with some potent ideas or very strong ideas on how to give a compression while not compromising the image quality. Another that we are looking forward is a potential shift towards a non-compression imaging method. Any technique where we can identify the breast pathologies without giving any kind of compression, like CT scan, MRIs, ultrasound, any other innovation in the mammographic, in the breast imaging technology, where we can completely eliminate the need for compression and the patient discomfort without losing the patient's financial credibility, and they can all opt for the same kind of procedure at a screening level and at a diagnostic level. That would be it for today. I would like to thank everyone for choosing me to be the guest speaker. Thank you very much for listening. Hope you all have a good day and we all go home with a good learning. Thank you very much.
Thank you very much, Nudeep Kaur. We had a wonderful session from you, including research and innovations in compression pad during mammography. Congratulate. So we will move the next session. Before that, I've seen a few of questions there in the chat box that will be answered after the last topic, the last speaker. So we are moving to the next speaker. The next topic is adaptive radiotherapy. We have Mr. Rakesh Kaul, who's the working as a chief radiation therapist at Max Hospital, New Delhi. And sir have pursued MSc Physics, 1 year certification courses in medical physics from Baba Atomic Research Center, Mumbai, Srinagar. And sir has a vast experience of 41 years in a professional experience and 30 years of teaching experience. Sir have organized more than 40 seminars, conferences, and teaching workshops. And sir presented more than 450 presentations across national and international level. So sir has 7 publications in national and international journals. Sir also member of external examiner and guest faculty at Rajasthan University Health Science from Jaipur. And sir is the auditor of Health Sector Skill Council, New Delhi. And he was an ex-vice president of ARTTI, the Radiotherapy Association, the ex-general secretary of ARTTI Northern Chapter, and he's presently vice president of ISRT Delhi Academic Club and regional coordinator ISRT of NCR Rajasthan. So with this note, I welcome Rakesh Kaul, sir, his presentation. Over to you, sir. Dear participant, will be issued as e-certificate by the organizer, the later part. So if you have any queries, put the
Good evening to everybody. I'm privileged and honored to be the part of this event, and today is the 46th CPD program for Asia Radiological Technology Society. I extend my sincere thanks to Mr. Bohan Bhagwat, ISRT President India, General Secretary Mr. Suresh Maliha, and my special thanks goes to Mr. P.G. Luna, Secretary General CPD Program. Thanks to my topic. Today's topic is adaptive radiotherapy, and myself Rakesh Kaul from the Max Hospital, Department of Radiation Oncology, New Delhi. Today's topic, which is adaptive radiotherapy, and as we know that that the aim of the radiotherapy is to achieve the tumor control by the homogeneous radiation to tumor-bearing tissues. and at the same time to avoid radiation-induced complications by minimizing radiation dose to normal tissue structures. This way, we can increase the dose conformity and also increase the tissue sparing. And at the same time, we can reduce the plant complexity. Now, the learning objective of art. So the basic objectives are to gain the working definition of the adaptive radiotherapy, to understand the technical and process components needed for adaptive radiotherapy, for plant adaptation. That means in between the fractions, we can evaluate and we can clinically assess the things, and also on the online before delivering the radiation treatment. So before that, we need to understand what is IGRT. IGRT we call the image guided radiotherapy. So in this case, an imaging system that allows for increasing the precision by frequent imaging the target and healthy structures just before treatment delivery, and then acting on these images to adopt the treatment. That means we take necessary steps, whatever is needed for the adaptation of the treatment plan, or to correct the position of the patient so that the highly precision is followed for treatment delivery. IGRT seeks to address geometrical uncertainties in dose placement for target and normal tissues. IGRT reveals anatomical and biological changes during radiotherapy. So the goals of IGRT is how does the relevant anatomy move or change, and at the same time how fast does it move at varying times, because it differs from the patient to patient and tumor to tumor, and how and when to measure it, which is very important, and when to correct it, how to correct it, and how does one determine the efficiency of the correction method is very important in the goal of the IGRT. Look at this one of the pictures. Is this a change in the neck curvature during the CT planning? You can see on the left side image, the picture is taken, and you can see there's a lot of curvature. But when we have taken the patient on the treatment coach, and we have found during our CBCT image, that's the volumetric image, we have found that the neck is straight. The patient is very comfortable. That means during the treatment planning, the patient was stressed, so he has extended his neck too much, and during the treatment, he's feeling comfortable. But treating in such a position is not appropriate, because we are defeating our goal, that's in the precision of the radiotherapy. So by simply correcting this core shifts is not allowed in this film, in this case. So we need to replan it and resimulate it. So then you can see the another example where we can see that the CT the patient is a very straight line, but on the coach there is a lot of roll, and also the rotation at the lower neck. So again, we can't correct it, and if it continues for 2-3 days the same pattern, so we have to take a decision. That decision could be replanning and resimulation. So now what is art? So art is basically the incorporation of the delay image into the radiotherapy process. These to adaptive radiotherapy. In art, the treatment is evaluated periodically, and the plan is adaptively modified for the remaining course of the radiotherapy. Image registration between the planning image and the delay image is a key component of art to account for temporal changes in anatomy. So that art can occur at 3 different time scales. That is offline between the fractions. That means if we take the image, and that clinician can evaluate these images after the treatment, and if there is any clinical change he finds, and he can take the decision for adaptive radiotherapy or continue with the same plan. Is the MRI Linux, where the plan is can be modified, because there's particularly in the prostate case, there's a lot of change during this treatment. So plan is evaluated at the same time, and new plan is modified, and replan is done at the same time before treatment delivery. And in real time, during a fraction during the treatment delivery, this is the best example is the that gated tumors, or we can say that when we change the tumors, the that's the moving tumors, that is in case of the lung tumors and the liver SBRT. And we at our center have an exact track system where we change the tumors, and any changes can be taken during the course of the treatment. So the term adoptive radiotherapy summarizes any reaction to changes that manifest during a patient's radiation therapy course. A change in the original treatment plan is implied. There could be a tumor shrinkage, and there could be a tumor growth also, and maybe there's a weight loss in the patients. So you have to take the appropriate decision. And change in hollow organ or cavity filling, that means there could be a pleural effusion also, seroma in case of the breast, and gas or rectal filling. So if these changes can push the PT to different areas, and where that we are irradiating unnecessary normal structures and missing the tumor. So in these cases, we have to take correct decisions for the planning. And sometimes the patient is not comfortable in simulation positions. That could be a fit case for adoptive radiotherapy. Loss of compliance, a patient is not cooperative, new onset of pain, and so many other things where the patient's image matching is not appropriate. So all these requires a simulation and planning. So if we look at the conventional workflow of the radiotherapy, because when the imaging system was not integrated in the machines, in the Linux, so we used to do the simulation and mold preparation, and then planning, and straightway to tumor without taking the image. But with the technological development in the field of radiation oncology and the parallel development in the field of imaging technologies, we have been able to reduce our PTV margins, and also take imaging, daily imaging. That's why we are discussing the ISRT previously. So the workflow is the simulation. We simulate the patient after making the mold, and that we generate a good treatment plan. And after this treatment plan is generated, treatment execution is done. And before that, we take the online images, which is verified by the radiation oncologist on the first day. And if everything is okay, then we continue for the treatment. And if there is any change, not only the first day, but in the future course, then we go for the adoptive radiotherapy. And if we go for that, that means we have to abandon the treatment and replan and follow this circle again, that right from the simulation to treatment delivery. So why adoptive radiotherapy? So why we need to go for adoptive radiotherapy? Actually, we treat patients with the assumption that the shape, volume, and relative position structures will remain same throughout the treatment, which we used to do in the back in 90s, that time when imaging tool was not there. So in reality, patient is a dynamic. There could a lot of change could happen during the treatment course, as we discussed earlier, that there could be tumor shrinkage, there could be weight loss, or there could be this pleural effusion, and so many things could happen. In reality, in reality, as we said, the patient is a dynamic. So normal organs contours change less in comparison to tumor with course of radiotherapy. So position of organ and risk changes more. So now IGRT also mean the adoptive radiotherapy. So tumor hopefully responds to treatment and shrink over the course of therapy. As the surrounding tissues are pulled inward, the result may increase the dose to the critical structures, because PTV shifts that maybe a kidney comes in between, or some critical organs come in between. So the dose is escalated on those areas which are the organ at risks. So with adoptive radiotherapy, goal is to use images to perform online setup corrections of patient positions. If your volumetric images automatically detect any change in the target shape, automatically adopt the treatment plan to reflect the new target shape, provide the therapist with important information on how the plan has changed, deliver the new plan. So in short, that adoptive radiotherapy involves the modification of the initial plan. That means when we started the initial plan, but if there are change has happened, so we need to abandon that initial plan and go for a new plan. So how to recognize these adopted adaptive at different levels? We have to adopt these this adaptive adaptive. It can be at the clinical assessment. That means when clinical assessment is done, clinical review is done, where we can see the patient's history from the day one to what is happening during this patient. There could be loss of loss of weight, shrinkage is there, our patient is not comfortable. So clinical assessment has to be done by the clinicians. Or poor fit of the immobilization devices, the cast is not, it could be that cast is very tight or it is loose. So that time we have to take a decision for the planning. So these can be taken through image guidance. So image guidance tool should be the integrated part of the LINAC machines. Then only we can recognize the need for art. And patient complaint. Patient complaint is that maybe patients completing the pain at the other side to say he's developing pain in the metastatic in the bones. So if he complains, then we have to see what the decision have to take at that time for adopted adaptive. So art has the three basic components. Is the detection of the change. We have to detect the change, what has happened. It could be through the imaging or by other what we can examinations or other imaging examinations or other things we can do it. So then we have to look what should be the method of the intervention, when to intervention, how to intervention, and what are the steps should be taken for the intervention. And management of overall clinical goals. When we take up the talk of the management of overall the clinical goals, that means we should have a proper protocols, proper set of rules followed by the department, so that when we see there is a change, that we have to follow these protocols, then our treatment efficiency can be increased. Ideally, direct staff inputs must be replaced by the automated process to make the art practical. So I just taken a data, randomly I have taken a data that from 1st November 2023 to 31st May 2024. This data was taken on the Novalis TX linear accelerator, where we have treated head and neck cases, 75 cases we have taken treated, and we have seen their tumor regression in 11 patients and weight loss in two patients. And simulation discomfort was not observed in any patient. So in total, we have planned 13 patients for head and neck case out of the 75 cases. Similarly, for thorax, we have taken 15 patients, but tumor patient discomfort in simulations, and total replanning was done in 7 patients out of 50 cases. Rectum and prostate cases. Tumor regression in 3 cases. There was and we have replanned 5 patients out of 55 patients. So these are the examples. You can see the target volume increases cannot be corrected by simple course shifts. You can see this is the planning CT, and after 2 weeks of treatment, you can see there instead of the regression of the tumor has aggressed. So in this case, we need a replanning because we have to include the area where the tumor has increased. So in this case, it is a definitely fit case for the replanning, and we call it adopted adaptive. Now you can see this the planning CT, another head and neck case, and is the first fraction. There is similarity between the planning CT and the first fraction, but within the 4th week, there is, you can see the gap between the cast and the patient body, lot of gap. So it's a fit case of replanning because there's a lot this weight loss. So another weight loss you can see at the cervical level for the another hierarchy in the fourth week of the treatment. So we have this planned. This patient recasting was done, replanning was done for and continued with the new plan. Now you can see the anatomy change. This is the these are the tumor size here you can see, and this is the parotid region. So now after 10 days of treatment, you can see there's a regression in the parotid, and tumor has also shrunk. So fit case for this adopted radiotherapy. Now, another case, you can see the planning CT, first day CT, these are similar, and CBCT after 13 days, there's a regression in the tumor. So when there is a regression, you can see the gap. So we have gone for the replanning. Now it's the lung tumors. You can see organ motions are there in the lungs. You can see the first week of the treatment. Second was there's a little bit regression. Then third week also regression. But on the fourth week, we have seen there's a lot of regression. So we replanted it, and till we continue the treatment was planned for 6 weeks. So after 6 weeks, the tumor was reduced to almost vanishing level. So the patient response was very good. So another case of the lung cancer is a planning CT, and after 6 fractions, you can see how much the regression of the tumor. So continuing the treatment with the same plan was not advisable. So this replanning was done for this patient. Now, moving target within the pelvic, in case of the prostate, motion predominant, motion causable variation, the rectal and bladder filling. You can say that in day one, rectal filling is almost there is no, but we can see on the third day, there a lot of gas and rectal filling is too much. So in this case, we didn't do the replanning, but intervention was done. So is another example. You can see this, the bladder was filled, this is the rectal position. And when we see that this on the CBCT with structures we have seen that rectum has moved into the PTV margin. That means the rectum has received is going to receive much higher dose as compared to what we have planned. So in this case, we have intervened in this case, and this enema was given, and you can see that then the plan was corrected by this way, and you can see the rectal position of the CT scan, and the imaging was almost similar, and we could give a appropriate dose to the rectum. And this is the rectal filling. You can see in this case there is the CT image, rectum is collapsed, but in CBCT you can see that rectum is filled with is distended. So intervention is done, and so as to bring rectum back to the same position as the CT, we can see there. Again, the enema was given in this case. Now is a third case where you can see the bladder is volume is this much on the CT image, but here we can say there was inadequate bladder. So it is not appropriate to treat with inadequate bladder. So we have changed our bladder protocol, that we have increased his that intake of water and increased the waiting time for this, so that to reproduce the same volume of the bladder during the treatment. So there are so many cases like CS cervix. There was a first week treatment was done, and in third week we have replanted it, and because of there was a good response, the tumor was regressed a lot. So these are some of the examples where we can go for adaptive radiotherapy. So advantage of the online correction is IG offers the possibility of significantly enhancing the accuracy and precision of radiation therapy methods. Important advance in terms of the margins reduction to better limit the dose to critical structures may reduce the toxicity of radiotherapy. Additional gains are monitoring the treatment response, weight change, and organ filling on day-to-day basis. So adaptive, if we summarize the adaptive radiotherapy, correct strategies based on observed patterns of site-specific anatomical change has to be observed. Quantification of change is important, but meaningful plan modification should be the goal. It is not that we should go randomly for applying all the patient, but there should be a meaningful way to do it. That meaningful means that we should have a set of protocols and rules when to intervene. That's the best way to do it. And one mid-course CT should be done to see what is happening inside the, even if IGRT solution not available. That means that those centers where there is no integrated imaging system available in the Linux, or the patients who are doing the treatment on the cobalts, they can do a one midway CT to see the response of the tumor. So if there is any change, they can adopt the treatment plan accordingly. And now the logistic is a big issue. So increasing workload for all staff and the increased physicians' time spent on recontouring target volumes and normal structures, additional financial burdens of reimaging and planning, and some of the financial burden is on the patients also. Is it possible to daily replan? No, it's not possible to have a daily plan. So we have to follow the strategies. We have to set the protocols as said earlier. Can the process be made efficient enough for the busy clinics? Yes, by following the set of the rules, by formulating the rules. Is time and resources spent worth the clinical gain? And what is the clinical gain, if at all? That, as we said, that our clinical gain is to achieve the high precision of radiotherapy, that is by delivering the appropriate dose to the tumor and minimizing this normal tissue toxicity. And yes, it is worth to spend time and resources on these things. Now, in conclusion, IGRT cannot address volume change, deformation, and rotation. And adaptive radiotherapy, whether it is can be observed on the online and offline, address the anatomic change such as translation, rotation shifts, deformation, thereby eliminating the need to reposition patient. Art takes into account patient-specific treatment responses. Art replanning leads to improved target coverage as well as normal tissue sparing. So if we are able to save the normal tissues, reduce the PTA margins, we can escalate our dose, and which is very important for the best treatment delivery. With these words, I thank once again to the organizing committee for giving me the chance. Thank you very much.
Thank you very much, sir, for the wonderful session. It was very informative, and we are able to understand the topic. With this note, I'll finish. Few questions are there in the chat box and as well as the YouTube channel. So first, I like to ask the question to the Professor Paneerselvam, sir. Sir, Paneerselvam, sir. Quickly, I like to finish two to three questions. Professor Paneerselvam, sir.
Yeah, please tell.
Yeah. The question by asked: how should the operating room to be set to accommodate the interoperative MRI procedures?
Okay, actually, the operating room will be as usual what we do it. Apart from that, before shifting the patient to the adjacent MR room, we also have a MR compatible devices which the patient has to be accommodated during the procedure. See, for example, if a pulse oximeter is needed or if a multi-parameter monitor is needed, if they are going to be in the operation theater, it can be a regularized one, but it should be make sure that you also have a MR compatible before shifting to MRI shoot. It doesn't mean that always will be shifting to MR. Whichever cases which we are planning to shift it, So before, that is the reason I told you that the team coordination should be there. The team coordination, in the sense when they have decided that they are going to shift to MR for an imaging, make sure whatever with the patient as well as the devices which you are going to be taken with the patient, that should be MR compatible.
Okay, sir. Thank you. Thank you for the answer. And as well as there was another question, you are answered. What are the surgical instruments and equipment are to be used during MRI?
Yeah, as I was mentioning, you will be having a normal devices, but when you are planning to shift, it has to be accompanied with MR compatible. It's something like a what you call two sets of devices you will be having. And in case there is a second configuration, which I told you, the MR equipment itself will be coming to the operation theater, which is a ceiling mounted. In that case, the whole suit, MR suit, as well as the operation suit, should be only MR compatible devices.
Okay.
That is very expensive. That is very expensive. That is the reason normally the first configuration is used. For example, in India, in NIMANS, we have that setup where there are 3 operation theater with the MRI suit. So patient from the different theater can be shifted to the MR room.
Okay. Thank you. Thank you so much, sir. Quickly, I'll two more question is there for Ms. Anudip Kaur. Anudip Kaur, can you be able to hear me?
Yes, sir, I can hear you.
Yeah. So there is 2 questions in chat box. I'll ask at a time. Will the cushion compression cause artifacts? Can radiation pass through the thermoplastics? There are 2 questions. Can you answer?
Good evening, everyone. Thank you for the opportunity. And yes, to answer the doubt, the cushion compression will cause a bit of artifact. And there have been study conducted around it. If you want to go, you can read it. The study is named, it's about the report on the PubMed study, you can see. And it found out that in 2% cases, there was artifact generated due to the cushion being used. And the artifact is basically your edge shadowing and the blurring. And that happens because the cushions are not uniform, right? Because of the non-uniformity of the cushion when the breast is placed over there, and sometimes overlapping of the material, that might also contribute to the artifact. So these are the 2 artifacts that we have come across while using the cushion compression. And the material thickness will also matter, but not so much to contribute to it. Usually the material used is of the radiolucent capability. So the remedy which you can use is, first is make sure the system being used for the foam pad is a radiolucent. Secondly, make sure that the technologists have got the proper training while placing the breast so that the density is evenly distributed. That will really enhance your image. And lastly, it can be if you are making sure that quality control is regularly checked. Because if the foam pad has got any kind of, if it's not cleaned properly, it has a dust on it, that might contribute to an artifact. Otherwise, there is no such artifact to be known so far. And to answer
Can you answer the second question?
Yes, and to answer the second question about the radioplastic sheets being used, the material composition, again, it only depends on the material composition, right? So basically, in the standard thermoplastic sheet, what we are using is our polycarbonates and acrylic, right? So there have been studies conducted around it as well. And the study included polycarbonate as a material, and that included nylon as a material. And there's another material that was experimented with, that was polyethylene terephthalate. So these 3 materials and other materials were experimented with, and they found out that polycarbonate does have a bit of higher X-ray absorption efficiency compared to our PET and our acrylic and nylon. So those are the 2 interventions that people are looking forward to develop, because the radiolucency of the material is what will contribute to a good image. If you have a good translucent material, you will have a better image. Secondly, the thickness of it. If you keep the thickness between 2 to 3 centimeters, which is the standard thickness that we are using, then there is no such complaint of artifact. But in case the thickness is beyond 5 millimeters, there are complaints of certain absorption of the radiation, right?
Okay.
Again, we use low energy x-rays in mammography, so that also has to be kept in mind, because the energy being used is 25 to 35 kVp. If you are using a low energy, we need to make sure the absorption again is very low. And so far, polycarbonate has been used, but I think nylon will be the new substance that people are experimenting with and might be replaced with it.
Thank you. Thank you. I hope
Thank you so much, sir.
the participant received the right answer. And thank you very much, Anudeep. We have
Thank you,
last
sir.
question, Mr. Rakesh Kaul, sir. You able to hear me?
Yeah, I can hear you.
So, what is the difference between the adaptive therapy and the conventional therapy? That was the question from the participant, sir.
Actually, in conventional radiotherapy, it is presumed that in conventional radiotherapy, we presume that everything will be the same from the day one to day first treatment to the last treatment. But actually, there are a lot of things happens during the treatment. What we can say that there could be a regression in the tumor. When there is a regression in the tumor, that means what we have planned, this tumor may shift to the critical organs also. So in that case, we need to intervene. That means we have to reduce that our treatment area and replan it.
Okay.
So that's the imaging is the very important part. Also, not in the adaptive, in the conventional radiotherapy, there was no concept that we assumed that only the tumor can shrink. But in certain cases, we have seen that sometimes the tumor doesn't respond to the treatment. And instead of the shrinkage, the tumor gets aggressive, it gets its growth increases. So in that cases, we don't want to continue with the same plan. We may need intervene. Maybe we can adopt it with the put the chemotherapy also in between. So that's a clinical decision. So that is why there's a difference between the conventional and this adaptive. And in conventional, the margins were a little bit more, and the toxicity was high. In adaptive radiotherapy, in IGRT or MRT, we reduced the PTV margins. So that we deliver the high precision radiotherapy and at the same time reduce the toxicity to the normal tissues.
Okay. Thank you so much for answering the question, sir. So here with the I'm ending the moderating the session. So with this note, before handing over to the next person, I like to thank my mentor, General Secretary and CEO of Mr. Suresh Malliath, for giving me the opportunity. And I thank each speaker, Professor Panirselvam sir and Rakesh Kaul sir and Ms. Anudeep, for the wonderful talk and the sessions. So with this note, I will hand over to Pichi Luna madam for the further. Thank you very much.
Yes, thank you to our session moderator. Yes, thank you to our session moderator, Mr. Shashi Kumar Shetty. Thank you to our presidents, our panelists, to our three excellent speakers from the ISRT who recently gave insightful presentations and sparkled a lively Q&A. Again, thank you, Panir Selvam, Ms. Anudeep Kaur, and Mr. Rakesh Kaul. We have learned so much from your discussions, and we hope to hear more next time. So we also would like to congratulate the CPD Asia host, the Indian Society of Radiographers and Technologists, ISRT, to President Mr. Mohan Lal Bhagwat, all your officers, your CPD ISRT organizers. I know everybody's excited for the next CPD Asia scheduled next month. And so to give us an invitation, I'd like to call in the President of Malaysian Society of Radiographers, MSR, Mr. President Sawal Marsait. President Sawal Marsait. So I guess while we are waiting for him to reconnect, I'd like to call in first the ISRT spokesperson, Ms. Naheda Ahmed, to give us a vote of thanks. Miss yes, Miss Syed Naeda. Oh, so we are all right. So wait. All right. So I guess we have here now the president of Malaysian Society of Radiographers, our dear president, Mr. Sawal Marsaid, to give us an invitation for the next CPD Asia next month. Mr. President.
Okay, thank you, Madam Pichi. Just now because I can't unmute myself, so now only I can. So thank you very much, Madam Pichi, for the opportunities given to MSR. And on behalf of Malaysian Society of Radiographers, or MSR, I would like to invite all of our friends across Asia to join us on the 22nd of March 2025 at 9 a.m. For the 47 CPD Asia, with the title of Radiographers at the Forefront in Optimizing CT Exposure and Image Quality. So at this CPD Asia, we're going to have 4 speakers with us, which is I can move this one, which is Dr. Nur Azura Muhammad. We'll be talking about principle of CT imaging and radiation exposure. The second speaker with the essential of CT image quality, parameters and trade-off, from Associate Professor Dr. Muhammad Hanafi Ali. And the third speaker, the advancement in CT technology and their impact on radiation dose, from Mr. Esnu Halim. And for the last speaker, with the title of Role of Radiographers in Optimizing CT Protocol, is from Associate Professor Dr. Akmal Sabaruddin. So please join us during the CPD Asia on the 22nd of March 2025 at 9 a.m. Malaysian time. So this is the tentative program for the webinar, and hope that our friends across Asia will join us at that webinar. Thank you very much, Madam Pichi. Thank you.
Thank you very much. There you have it, the invitation from the President of Malaysian Society of Radiographers, dear President, Mr. Sawal Mars. We will definitely save the date. It sounds very interesting. So finally, let me now invite the Indian Society of Radiographers and Technologists ISRT spokesperson, Ms. Naeda Ahmed, for the vote of thanks.
Good evening, everyone. Hope I'm audible. Yeah. Okay. So on behalf of ISRT India, it's my great honor and privilege to extend a formal vote of thanks to one and all who have contributed to making this event a grand success. First and foremost, our deepest gratitude goes to Ms. Pichi Lona, Secretary General of Asia CPD Programs, for her enthusiastic coordination and tireless efforts in making this event possible. Madam, your dedication and commitments have played a key role in ensuring the smooth execution of this gathering, and I can say all the Asia CPD programs. So thank you so much. A special thanks to all Asian radiological technology societies for their valuable support and participation. Your collaboration and shared insights have enriched our discussions and strengthened our professional ties across the region. We are immensely grateful to our moderator, Mr. Shashi Shetty, for skillfully steering the event, ensuring seamless communication and keeping the session engaging and insightful. To our esteemed speakers, Professor Puneer Selvam, Mr. Rakesh Kaul, and Ms. Anudeep Kaur, I extend my sincere appreciation for sharing your knowledge, expertise, and experience. Your contribution have added immense value to this event, inspiring us all. A heartfelt thank you to our President, Mr. Mohanlal Bhagwat, and immediate past President, Mr. Selva Kumar, for their guidance, leadership, and unwavering support in driving the vision of our society forward. A special acknowledgement to Mr. Mahesh for his exceptional effort in organizing this event and providing outstanding technical support throughout. Your behind the curtain work has ensured a flawless experience for all the participants. Lastly, but most importantly, our profound gratitude is due to our General Secretary and CEO, ISRT, for being the vital link that connects us with the international society, ISRT, and with all Asia Australasian countries, and for leading ISRT with dedication and vision. Sir, your leadership continues to strengthen our profession and global presence. I thank each and every delegate attending the event for all parts of the world for your patience, listening, and your interaction. Once again, a heartfelt thank you to each and every one of your contribution, participation, and support. Wishing you all continued success and looking forward for future collaborations. I wish most of the Asian Radiological Technologies Society's presidents and council members join us in NCISRT 2025 at PGIMER, Chandigarh in September, as our General Secretary and CEO has already invited you all, and I appeal once again for the same. Thank you so much.
Yes, thank you, Ms. Nahida Ahmed. Thank you for that. So once again, we thank you, and we shall meet each other again in the next CPD Asia online program next month. Let's embrace this opportunity to learn, to innovate, and grow together. Thank you again for joining.